Okay, hello everyone. Welcome. This is the second in our series of pressure point events, and this one's about AI, which is, I guess, our favorite subject. I guess for many of you, you'll be on some kind of AI journey. You'll either be new to it or very familiar. The beauty of this field is that no one really knows everything. We've got a lot of experience here of working in this area and also of teaching it as well, and we'll give you a flavour of our perspective on it and some of the things that we go through in the courses that we run. I think it's worth pointing out that this is the largest audience we've ever had for this kind of thing. So to our studio audience, thank you for being here. To everyone online, now there's about 3,000 people, which is a record for this event, and 50% of you are in the US, and then the other 50% are equally distributed across all the territories around the world, which is great. So wherever you are tuning in from, we really appreciate you taking time to be here for this discussion. We've got an amazing panel, and I'm going to get them to introduce themselves in a second. A bit of housekeeping stuff first. So we have, for those of you on YouTube, there's basically an audience poll that you should be seeing, which will ask you the question like, which topics are most important to you? And so please comment on those as you see fit, and we'll try and include that in the discussion as we get a little bit further on. So other than that, we're just going to get to it. So I'm Trishan, I'm an alum of the school, Harvard School of Public Health, and I broadly with Heather run the executive and continuing education program on AI, and we have a certificate program that Santiago, Heather and I teach, and we have 3 courses, and we'll tell you about them at the end. If you like what you hear now or you want to know more about it, then that's where you can find out more. And to my right is Professor John Brownstein from Harvard Medical School, Emily Lindemer, Heather Mattie, and Santiago. I think we're going to get into it and just start with, I guess, what many people will be wondering. So all of us have come into this field basically from somewhere else. Mm-hmm. And that's the beauty of it, I think. There are obviously a lot of AI researchers in this field, but then it's so broad that there's people from lots of different disciplines. And obviously we're not all here assembled by accident. I've kind of picked people from different parts of the story, but it'd be great to know what your journey into this field was and what you're working on now. John.
Great. Well, thanks so much, Trishan. It's great to be here with a great group. And so my name is John Brownstein. I am an SVP and Chief Innovation Officer at Boston Children's Hospital. I'm also a professor at Harvard Medical School. I've been at Children's and Harvard Medical School for over 20 years now. And so my journey around AI has really been over the last 2 decades. My background is in public health and epidemiology. And so a lot of my research work has been thinking about unlocking data sets that can help us understand the health of populations and forecast future risk. So very early on, there was the recognition that there was huge amounts of data online and through electronic medical records, but it wasn't being harnessed in the right way. We didn't have the right methodologies in public health to really think about these large data sets, whether they were generated by individuals on social media or on search query data from Google or health EHR data, which was really largely untapped. So working with colleagues in industry, companies like Google and Twitter, Apple, Facebook, and others, we started to understand how to unlock that data and use novel methods. And they were not the same methods we're seeing today, but they were early methods in machine learning to start tapping into that information. And we sort of coined this field of digital phenotyping. And that was really the starting point for me in AI, where I recognized there was all this untapped data that with AI, we could really bring some key insights. In my role at Boston Children's, I took over the innovation program, and that includes all the digital health efforts at the hospital, virtual care, remote patient monitoring, online second opinion, and really the entire AI portfolio of the hospital. That's been ongoing for well over a decade with narrow machine learning areas like in radiology and pathology in the ICU, which are very data-rich environments. But over the last few years, it's really transformed with the advent of generative AI. And we'll talk a little bit about some of those use cases. But what we have now is an organization at Boston Children's that is deeply leveraging AI tools for pretty much all aspects of healthcare delivery, whether it's on the research side, the administrative side, and on the clinical decision-making side. And so dozens, if not hundreds of now use cases are being deployed within the hospital.
Good stuff. All right, look forward to hearing about that. Emily, welcome.
Hi, everyone. I'm Emily Lindemer. So I am an alumna of the Harvard-MIT HST program, and I studied computer science there, but it was around the time where CNNs were being used to determine if something was a cat or a dog. So, I did not kind of train in what AI looks like today at all. But it's interesting, right after I finished grad school, I was one of the first applied scientists at IBM Watson Health in their imaging division. And back then we were working on methods to predict breast cancer from a mammography or to screen positive versus negative. And it's funny because throughout my journey in industry since then, I still actually see us working on the same problems despite quite a lot of advancements in AI. But after I was kind of an applied researcher in industry, I took a little bit of a turn and went more into health services and digital health in different kind of management roles of data science and product teams. And I found myself getting very frustrated with some of the problems that John alluded to, which is that the data is so fragmented. It's very hard to harness data sets that are large enough to do interesting things. And at the same time that I was feeling those frustrations, generative AI came on scene. And so I joined an incubator called Shaper Capital that was founded by the same gentleman who founded Datavant, which is a data fragmentation company. And their purpose was to spin out companies that solve data fragmentation issues. And one of those companies is called Protégé, and we work in specifically in healthcare data for training AI. And I'm the head of product there now. And so today we are actually the biggest supplier of healthcare data to essentially all the large foundation models out there building models in healthcare. So it's a very exciting time to kind of be at the middleware layer of kind of supplying the AI ecosystem.
Excellent. Thank you, Emily. All right, Heather.
All right. Hey, everyone. I'm Heather Mattie. I'm a lecturer on biostatistics in the biostatistics department here at the Chan School. I also co-direct our health data science master's program. I was a PhD student actually in the biostats department before becoming faculty. And during my dissertation research was sort of introduced into machine learning methods and I guess sort of the early stages of AI, if you will, for health data. And once I became faculty after graduating and sort of starting to run our new, at the time, health data science master's program, got really into much more of the machine learning and computer vision projects. I taught a lot of the courses for that degree. And actually my students introduced me to attrition, who got me into working with industry a little bit, and we actually talked about where can these models kind of go wrong and be biased in some way and actually do harm, especially at scale when you're talking about healthcare data. And so that got me into sort of health disparities and algorithmic bias. And so now I've sort of been in that vein for a while, and I am also a big proponent of education. I love to teach, and so I work with Trishan and Santiago a bit with the executive and continuing education on AI and healthcare, and still do a lot of biostats and machine learning teaching here at the school.
Thank you. Thanks, Heather. Heather and I are used to doing this together, but we're on Zoom, so it's always like it's a bit too much information. Yeah. Anyway, Santiago.
My name is Santiago Romero-Brufau. I'm a director of AI and healthcare systems engineering at the Department of ENT at Mayo. I came to work in AI kind of a convoluted way as well, as many of us did. I did my undergrad in engineering, which kind of started me on the technology side of things. But then I did my medical degree. I haven't practiced medicine many years. Now I just do AI full time. But it really informs my interest. My interest is specifically in the deployment of AI systems and machine learning models into the healthcare environment, particularly in the clinical setting and the clinical workflow. And that's essentially my role right now. In terms of topics, I'm working a lot, or me and my team are working a lot on large language models, specifically using context engineering and kind of agentic workflows to identify the right set of information that the model needs to look at to help in whatever clinical problem we're trying to solve. And so I also teach at the school in a couple of the courses that we have for the master's programs, as well as the executive education.
Okay, cool. All right, we're going to go into like some of these topics. We have we had a little poll from the audience, which interesting question. I didn't set it, but it's an interesting one. So, how do you feel about the use of AI in healthcare? And I think it's interesting that the word "feeling" is used. I mean, this is emotional, I guess, and you know, you wouldn't. Yeah, it's like, how do you feel about statistics? Probably wouldn't kind of chime with anyone, but people have feelings about AI in healthcare, which is, and most 61% of people in the audience, I guess it's the remote audience, are optimistic. So I guess make of that what you will, but there are feelings, and I think this is like obviously incredibly promising, and a lot of hype and also a lot of fear at the same time. So I think the purpose of this panel, everyone, is we're trying to bring together thoughtful practitioners, people who are doing the work and also reflecting on the work, all of whom have academic backgrounds and are thinking about things rigorously, because there's lots of other places that you can go to and find all kinds of speculation. But what that does also mean is that we're going to focus on actual kind of practical things that have been done, rather than like speculating about the future and will we all be replaced by robots or not in 10 years time or 20 years time or whenever your kind of event horizon is. But with respect to that, John.
Yeah.
Okay, so there's like two kind of core elements of work here, right? There's a whole kind of research vein. Hopefully we'll get into that in a bit. But if we could kind of focus on the practical side of implementing these technologies, and then even that, you mentioned the clinical stuff, but then also maybe, I don't know if it's correct to call it administrative or would you mind talking about that a little bit?
Yeah, absolutely. I think when people think about where AI is going in healthcare, they automatically go into superintelligence, and they automatically assume what the role of the provider is going to look like. How is that going to change? Because now we're seeing so many of our providers using AI co-pilots in decision making. And as these tools get better, what does that mean in terms of the provider's independence of making decisions? Are they going to have a gravitational pull just to go towards whatever the tool is saying? What will their sort of independence be? That despite the fact that they're getting a huge amount of support as with these co-pilots. But if we take a step back, the AI tools that we're launching, and yes, we are getting into the clinical decision making, there's a massive amount of opportunity before you even get to there. We think a lot about the sort of back-end administrative side of a hospital and a health system that is trying to deliver best-in-class care. We're seeing costs rise. Margins are decreasing. The cost of drugs is increasing. We are seeing huge amount of pressure in health systems to deliver care in a really challenging environment. And so when we think about AI, these are the tools that are going to actually help us alleviate some of that burden. I often call this mundane AI. This is not just like the super exciting AI tools, but the boring stuff. Like, how do we support our administrators that are spending so much time moving data from one place to another, or responding to emails, or searching the web for licensing of a particular provider, or dealing with like NDAs and documents. There is so much back-end effort that goes on to delivery of care that we can start to solve for with what we call intelligent automation. So we at Boston Children's have an intelligent automation team, and we're going department to department, finding out what are people spending their time on, what are the things that are driving people nuts because they spend their whole day doing it. Why can't we just automate those efforts with some AI inside and start to allow people to work at the top of their license, and by definition not grow our FTEs at the same rate that we've been growing, which is really unsustainable. So for instance, in our supply chain, they get 30,000 emails every month about invoices, submitting invoices, checking on payments, and we have 8 FTEs that are just spending their entire days just responding to those emails. That seems like a job that an AI intelligence tool could do. Check for those invoices, check for payments, submit those payments. And so now we have an automation that is saving about 2.5 FTEs in effort. Those people are nothing left, they've just moved on to other tasks. And so collectively in our intelligent automation group, we've saved tens of thousands of hours to the organization. That eventually is going to contribute to sort of a reduction in the cost that we're spending in the delivery of care. So that to us represents huge opportunity, especially as we see those costs rise. Of course, we're going to go into other domains. We've launched things like ambient listening. Some people here may know that. That's the collection of the conversations between providers and patients, using that voice file to use to build a note. That's saving our providers hours every day in their ability to document our own patients. So it's not just a cost saving, but it's also a burden saving. It's a cognitive load saving on our providers, and we're extending that into our nursing.
John, so just ask a question, like, how did you get started with this? I mean, obviously, I think you've kind of made a great case that these are very sensible things to use AI for, that create savings for the organization, and those resources can be used productively elsewhere. I think that's a very clear case. But like, for many organizations, they're thinking, I'd like to do something like that, but like, they don't know where to get started, right? So like, where did all this come from?
Well, we're lucky enough at Boston Children's, but it's similar to many other organizations where there is an innovation group that was sourced to have individuals that could develop software, could think about UI and UX, that could think about business and strategy. And it was a very small group that has grown over time. The more that we've shown ROI in the things that we've built, or the startups that we've brought in, the more we've been able to get resources to put towards that work. So you can start very small. And now, of course, with the tools of generative AI, you don't need sort of a massive engineering team anymore. There's a lot that can be done with a single individual that's either a developer or is trained now to think about coding. I mean, now you're essentially a coder with AI tools. So I think there's a huge opportunity. Of course, there's the vendors that are out there. There is a massive environment where there's huge money going into both startups in the healthcare and the digital health space, as well as sort of the big players. We partner with our underlying EHR vendor, Epic, but we also have a big partnership with OpenAI and Google, and those companies are looking to partner. So you don't have to necessarily have those resources in-house. You can partner with the vendors that you already work with.
So there's like obviously a very coherent strategy around introducing AI that is like tied very much to the executive leadership of the hospital, obviously, which you're part of, right?
Right. So for us, like, if we can show the value in the cost reduction, and we have to go and report that, then that will unlock dollars to allow us to do the more exciting things, which is sort of, where can we take this forward? Where can we push the envelope into medical decision making? How can we affect outcomes? How can we improve patient experience? But I think the first step is like, okay, well, how do you show some return on that direct investment? And that can unlock a further
Interesting.
amount of
so that's
resources.
kind of base camp. Okay, cool. All right. Emily.
Yeah.
Okay, so I think there's, in general, so we're going to kind of move around the areas a little bit because we just have to. The area is also very broad. We've got a limited amount of time. So I think, one element of this puzzle is the data that goes into making the models, be they the massive foundation models or smaller, more dedicated ones. And you talked about the fragmentation of that area and how that affects performance and even bias and these issues afterwards. So it'd be great if you could tell me a little bit more about what you're working on there.
Yeah, so as I said, I think data fragmentation has been the problem that has annoyed me the most in my career, and hence why I decided to kind of actually work the layer below the actual model building. I feel very passionately that is actually just so important and often sometimes overlooked. And so what I think is really interesting is that the nature of the data that we needed and how we thought about data being important underwent a massive shift with generative AI coming on the scene. So before generative AI, I had been doing a lot of work in kind of more just traditional predictive AI, a lot of clinical diagnostic work. And one of the most important things is making sure you get a really, really diverse set of data from lots and lots and lots of different types of institutions, and making sure you're representing the full kind of diversity of the population. While that is still true, this interesting thing has happened with generative AI, because the point of generative models is to generate very context-rich, in-depth, descriptive responses. That means that they need to see very context-rich, descriptive data to do that well. Where does that data come from? It really comes from academic medical centers and kind of like the biggest and the best health systems that have really good longitudinal care, really good clinical documentation. A lot of more rural hospitals, places that only have kind of single point in time care, they don't have a lot of patient follow-up, they lack that really context-rich data. So they become less useful for training these generative models, and then you kind of lose those types of patient representation. And so there is kind of this question of how do you keep that represented while you're making these generative models. So that's one thing that I've seen a shift, and we think about a lot, especially at Protégé. We see it as our responsibility to make sure you're continuing to represent that full diversity while you're more like limited to what is context rich. The second thing that I think is interesting is from a data perspective is the evaluation space. So there is a big question. There is how do you evaluate these generative models where there's not kind of one binary outcome, yes, no, this patient has cancer. You're evaluating them on how well they described or gave a generated SOAP note or an action plan for a patient. And a lot of the benchmarks out there, there's tons of different groups, academic groups, companies that are putting out these benchmarks to say, okay, I'm going to type in this full patient history, all of their symptoms, generate the SOAP note for me, generate the plan. And they are all kind of very, very clinical and curated by expert clinicians, which is great. You want your model to be as good as the best clinician. But what's interesting is that human beings, people like you and me, are going to ChatGPT to ask clinical questions. And there's not a lot of good evaluation data out there to see, is like ChatGPT good at having a conversation with a regular consumer about, information about my health. And so we are really interested in kind of creating evaluation sets on what we call user-generated data. So that more kind of conversational stuff that's generated by people like you and me and not just the best clinicians in the world, so that the consumer healthcare tools still feel safe and like up to a benchmark.
Yeah. It's, I guess it's super, it's worth reflecting a little bit, like in this foundation model paradigm, right, where we have like large pre-trained models that have been trained on the whole internet, plus curated data sets as well. I think the mental model that we've found a lot of the people taking our courses have of like there's biased data going in and then there's biased inferences coming out. It's kind of broken just simply by the scale of it, right? And also the fact there's so much going on at inference, test time compute, and also going on in the prompt. So I think it's worth reflecting for the audience that like that simple mental model I think that people have of like managing bias through curating data alone is very tricky with foundation models. Yeah,
I agree, and I think there's this kind of step in the model training process called reinforcement learning, where I think a lot of that is happening, where you're actually still putting humans in to check for these things. Is this model safe? And it's so easy to see AI in every headline and think it's like doing everything and taking over, and yet human beings are still deeply involved and have to be in order to accommodate for that.
Okay, so let's talk about that. So thank you. Heather, for the moment and for the foreseeable, possibly, human beings are still going to be involved in doing the work that delivers the AI results that John's been discussing and Emily's been discussing. And you have been for a while training those human beings, certainly the ones from here who've gone on to lead organizations implementing AI solutions and broader data science solutions. Yeah, like how are you thinking about it? Like in terms of what are the critical things that you're inculcating in the next generation of data scientists? And also, how do we evaluate the models to make sure that we're getting the performance that we think is both technically efficient but also equitable?
Yeah, it's definitely evolved over the last 8 years that I've been faculty and with this master's program running. It used to, very naively, I used to think that a bias was solely a technical problem or solely a data problem, which it largely was before large language models came onto the scene, as Emily said too. But what we're sort of realizing now is that, there are humans that are touching a lot of it during the process. Humans are inherently biased in many different ways. And so what I'm really trying to get through to my students and all the colleagues across academia, but also industry, is that we need to have diverse groups of people who are sort of checking what these models are producing, and are they being biased against a particular population or in a particular disease or something. And so not only do people with different expertise have different experiences and viewpoints on what bias actually means and how to detect it, but they also need to be able to communicate with each other. And so communication has been a huge sort of new skill that I've been trying to teach to my students. They're very technical, quantitative people in general. Communicating with people who are less technical or not technical really can be difficult. And so getting them to not only communicate well, but then also start thinking about what are the ethics behind this? What kind of governance should we be talking about or thinking about? They don't get a ton of ethical or ethics training, and so it's really sort of gone into the realm of regulation and governance, and now what I've also am sort of suggesting to them too as they leave the program and start working is to either get involved with or be on sort of a governance board, sort of putting guardrails on and checking the models and the model outputs. And
so governance board would be at like an individual healthcare organization?
Yes, or in a company or even an academic sort of center or lab or something, right?
Interesting. So it's like a multidisciplinary, I'm assuming.
Yes.
Yeah. Okay.
Yes, definitely.
Okay, and so and having data science representation on that as well as what else?
And like an ethicist and a clinician. It's very sort of context specific, but definitely a broad range. Since, as you said in the beginning, nobody knows everything, and or even where this is going to go.
Yeah.
So having people from a broad, realm of expertise is going to be fundamental, I think.
Yeah, excellent. I mean, it's kind of somewhat iconoclastic thing to say in this like hallowed organization, but the truth of this space is that no one knows where it's going and no one understands all of it, including us. So that's the truth. Thank you for that. So Santiago, just to come to you, like we had a second poll of the audience. Which of these topics are most urgent for you? And the number one was clinical decision support.
So I think when it comes to clinical decision support, one of the things that is important to understand is healthcare is not like many other industries where the organization is very top-down, right? If you work in, say, the fashion industry or something like that, and you develop a new algorithm to design better clothes or whatever, you can decide that centrally and say, well, this is how I'm going to design all of my clothes for one of the brands. And then I'm going to design it centrally, and then I'm going to distribute that to all of my stores. And immediately, those same, pieces of fashion, they're going to be in all of the stores. This is very much not how healthcare works. In healthcare, the decision making is distributed, where we have multiple people in different roles making different decisions with different pieces of input, which is, again, very much not how most other industries work. This makes it particularly critical for people that are in the world of healthcare AI or health data science to understand how those decisions are being made and understand the process and the workflow of the people involved in those decisions and how those are basically what is the relationship between the model and that workflow that we're trying to influence. So that is not only about the model development itself, is how is the model and its capabilities going to fit into the workflow, and how are we going to redesign the workflow to adapt to this new kind of piece of technology that we want to use.
Yeah, cool. And would you be able to share some of your experience of doing this? Like, obviously it's fairly extensive.
Sure.
So maybe one piece.
Yeah. So I've been doing this for a while. So I've accumulated a few case examples, but one of the early ones that I worked on was a model identifying patients that were deteriorating. So when a patient's in the hospital, typically they're at the sickest when they come in, they get better and better, and then they go home. Sometimes this doesn't happen like this. Sometimes a patient starts deteriorating and their condition starts getting worse suddenly. So we developed an algorithm to identify when this was happening. Because when this happens, this is a very bad sign, and it can lead to unexpected death. And we spend about half of the time of the project time developing the model itself. The other half was figuring out, okay, how are we going to use this model actually? Like, okay, we can identify when a patient is deteriorating with a level of accuracy. What are we going to do with that information? Do we put this into some sort of page where the physician can look at it passively, but they need to go look. Do we send them an alert? And then we tell them, hey, you may be taking care of something else, but like, do you need to go to take care of this other patient that is deteriorating? The accuracies, for example, that we would expect, that we would require for a system, in those two scenarios are very different. Because in one scenario, we know the physician is looking at it, so they probably have some time to look at it. Of course, that also requires us to, it's not as snappy, right? In the other scenario, we're actually interrupting the physician, which means we need to be so much more certain that the deterioration that we're detecting is actually there. So, this is just one example of kind of how these two worlds interact and how it's important to understand, and how the use that we're making of the technology impacts how we develop it.
And it sounds like you're doing fairly formal evaluation here, right? Like, and you're doing that internally, or you're doing that and publishing?
A little bit of both. Most
Okay.
of it we do internally. This is another one of my kind of pet peeves. Oftentimes, when you're doing an evaluation for a publication, your objective is a little bit different. You need to think about the broader applicability. When you're doing an evaluation for an internal deployment, you're not so much interested in how this will generalize.
Yeah.
You're interested in how, specifically for your population, how it. How it
And
comes
presumably
out.
you'll repeat it as you improve the model as well.
Right.
Yeah.
Yes. Exactly. Part of this is to develop kind of a maintenance plan
Yeah.
where you check the accuracy of the model and then it depends on how critical the model is.
Yeah.
You do it more often or less often.
Yeah, cool. Thank you. John.
Yes.
Hello. It's I guess this area, like clinical decision support, but I think I'm particularly interested in with your work, kind of some novel areas of medicine.
Yeah.
I think there was a lot of interest, and we have focused this discussion very much on the practical stuff. We hope we'll do more, and we can get more kind of future looking with where medicine, where healthcare is going with these technologies.
Yeah.
But already there are like signs that like novel areas of medicine are being opened up by AI, right?
Right. So, as I said, most amount of our resources are going into sort of present day problems and addressing some of the sort of the burden and administrative costs of healthcare. But we are making some bets that there's going to be a change in the way that we're going to be able to diagnose patients going forward. One of those examples is a partnership we have with OpenAI, where we had this hypothesis that we could actually extend our ability to diagnose rare conditions with large language models. So at Boston Children's, we run the Mattie Center for Orphan and Rare Disease, where we see some of the rarest and most complex pediatric diseases on Earth. And we get families that come to us looking for answers. They're on diagnostic odysseys for years, maybe decades. Oftentimes we can solve those cases, but many times these families are left without answers. And so that population is a consented group of families that is open to thinking about new methods of diagnosis. And so we went to OpenAI with this idea of, well, what if we combine sort of our best-in-class genetics researchers? We have data on phenotype and very deep insights about the conditions these kids are experiencing. Plus, we have genome sequencing that includes variants of unknown significance. Our collective genetics group has not been able to solve patients, but for some they have. And so we initially gave OpenAI a collection of solved patients. The initial work with OpenAI was really only a 10% hit rate, but working together and improving the models, and this is now baked into GPT-5, we are able to re-diagnose 100% by just giving this data. The big test, though, is like, well, what if we give it unsolved cases? And so we've now given OpenAI, in our collaboration, these unsolved cases, phenotype plus genetic data, and they've now been able to solve dozens of cases, which is really exciting because what's happened is we've been able to actually provide these families now with a diagnosis. In 15 cases, we've now provided these families with a diagnosis that we didn't detect before. Oftentimes it's because they've been able to mine the literature or find associations with genes and certain symptom sets. Sometimes it was just hidden data. Sometimes there was mislabeling in the data. So what we're moving towards is not just being able to replicate what our physicians can do. We're actually extending our ability. And this is not just for like diagnosis, but we're now moving into gene discovery and finding new pathways, and this ultimately leads to potentially new therapeutic development. So this is really where the field is going.
So like a co-pilot for genetic investigation, right? That's
absolutely,
essentially
from end to end. There's no reason why every geneticist on Earth, and when we talk about democratization, and I know there was a lot of questions about whether access.
Yeah.
Well, if we can bake this into the models, now it means that any geneticist on the planet can start to use these tools to then help support the diagnostic odyssey. So this is not just about the collection of expertise that exists within Boston, but that now we can start to think about making this available more broadly.
Okay, very powerful. Maybe I'll ask the other three of you, like kind of what are you working on, or what are you seeing that you're most excited about at the moment in this field? And if anyone wants to volunteer.
Maybe related to that, very related, I think, is that I think it's been very difficult to build any sort of AI in healthcare that's multimodal.
Yeah.
It's very difficult. You can train really great models on like the unstructured notes now on EHR data, but can you take into account the imaging, the histopathology, the genetic data? And so I'm very excited, again, from a data fragmentation perspective about our new abilities to start putting those together, because nothing is really just captured in the patient note. And what I'm even more excited about that I haven't heard enough people talking about, I think, yet, is that most healthcare and most healthcare outcomes are largely influenced by what happens outside of the four walls of healthcare. And so when do we start also bringing that type of data and information about patients into the mix? I think that will really exponentiate what's happening.
Yeah, could we just, sorry to, like, maybe for everyone is like, public health surveillance, or just public health outside of medicine, the impact of AI in that field. We haven't really discussed it. We haven't got a huge amount of time, so I don't know if it's something that lends itself to like quick conversation. Does anyone have anything that they would like to add in that area? I mean, John, you do a lot of disease surveillance,
I didn't want
right?
to take back the floor, but especially in a world of super constrained funding in public health, I've experienced that as still running a research group in this space. The ability to bring in these tools is going to allow us to do more with less, but it's also going to be able to do more beyond what we've been able to do with traditional public health surveillance. A lot of our work has been thinking about how to mine all the world's information about disease events, and we've run several tools. One recently launched with BU called Beacon, where we're pulling in data from informal sources, news, social media, and using the power of LLMs to categorize that information, filter it, provide context, and essentially provide reporting back to WHO, CDC, all our public health partners. And this is a system that works at the fraction of the cost of sort of a traditional public health surveillance system, because now we're using the power of LLM. It's not free, but it's definitely allowing us to do more in a world where there's very limited support for the kind of things we're interested in public health.
Amazing.
One of the things I wanted to add to that is I think one of the underappreciated side effects of LLMs and how efficient they are in terms of cost of compute is that they dramatically increase the range of questions that we can ask of data. Like a lot of the information that we have from a patient is in the form of a free text note, right? That before we couldn't really use very efficiently.
Voice file,
or a voice file, exactly.
Or video.
Yeah. And so all of that data now becomes available through the use of LLMs to generate hypotheses to understand kind of human health a little bit faster than we have before.
Absolutely.
Yeah, makes sense. I mean, I guess to Heather, Santiago, is there anything that you're particularly seeing either within your work or externally that you're excited about and would kind of like to share with our virtual audience around the world?
Yeah, in my case, the availability of data, particularly structured data that can be used, that's, I think, one of the things I'm most excited about. The other thing that I'm excited about that I don't think is quite there, but it's coming very soon, is the use of LLMs as agents. Kind of, little decision makers where we can control exactly what they look at and kind of having them do, for example, surveillance or helping with kind of somewhat cognitive tasks that are currently like one of a long list of things that we expect our physicians to do, particularly, for example, when we think about primary care practitioners. It will now be possible soon. We're not quite there, I don't think, But soon it will be possible to have, all these agents kind of crawling and checking. Oh, Mr. So-and-so hasn't gotten this thing checked. Let's send them a reminder. I think that can become very powerful very soon.
Great. Yeah. Heather?
Yeah, so one thing I've really loved seeing is that at a very local level, as I mentioned before, these governance boards sort of popping up within companies and institutions, and not only having different areas of expertise on them, but also a patient advocate to really keep the patients in mind. How is this going to impact them? What is this tool actually doing? Is it useful? If I tell the patient, hey, I'm using AI right now, are you cool with that? Do they even know what it's doing? Or, health literacy in general is probably not 100% for every single person. And so even, AI literacy now is a huge thing. And so not only do they have patient advocates to talk about this, they are really saying, how do we communicate this to the patient? How do we sort of get them on board, but also sort of understanding what we're doing, the data we're collecting, and how we're using it. I thought that was really powerful. And then I was thinking of a really cool tool. Oh, yes, in line with sort of health literacy and communication, sort of related to what Santiago was saying, but with sort of chatbots almost, or agents that can sort of call up a patient to check on them and say, do you have any questions about post-surgery issues or anything, and giving them reliable but also accessible health information. So I'm really excited about sort of that area.
Excellent. And then, Heather and I, actually we've all been talking about this recently, is maybe many of you have, it's somewhat controversial in the academics situation, but is like vibe coding, basically. Essentially, one of the most advanced, I don't know if that's the right word, one of the areas where AI has had most impact is in engineering, writing software code. And it really has been democratized hugely. And with, you've seen a lot of, maybe some of you use it, hopefully you don't use it on your coursework here, but in the executive education world and in the world of organizations where we're at, it's not so much about cheating on your homework or not, which I hope none of you are doing, of course, but it's about a generalist having many more data science skills, right? And Heather, that's something we've been looking into.
Yeah.
Like for physicians, business leaders of healthcare organizations, can they do much more of the data science work themselves
and then
with the modern
vibe
coding stack? Yeah.
Right.
So very interesting. I think it's hugely disruptive. I think also you can extend it to patients. This is the first generation of these tools. It should be that people should be able to look at their own healthcare data, ask questions, and the AI behind the scenes is writing the code to do it. But we will come on to that in the next discussion. But okay, we've got a few minutes left. We've got one question from the audience that I'll bring up. So it's not actually a particularly easy one to answer, but maybe we should ask it anyways. It's kind of come up a lot, which is essentially around oversight, governance, regulation. So how should AI in healthcare be governed so oversight keeps pace with innovation? Mm-hmm. I think I can just kind of shortcut the answer here by saying that I think we're probably of the belief that doing so at the national level is inherently complicated for technology that's developing so fast and is so general. Yeah. So then it's essentially delegated by proxy to individual organizations, right?
We signed there was an effort a couple years ago by the White House to sort of have health systems sign on to commitments around healthcare AI. So not necessarily regulation, because it is very hard, but there are coalitions that exist across healthcare, especially here in the US, where systems have come together. This one group called the Coalition for Health AI. And so there's a lot of knowledge sharing that is occurring in thinking about how to appropriately govern and effectively deploy AI tools. But it does have to be at the local level. Like at Boston Children's, we have an AI governance group that is made up of many different stakeholders, and we're setting AI policy. We're setting educational efforts. We're setting policies around the use of AI, the monitoring and evaluation of those tools so that they don't go off the rails. And so much of that is happening at the local level. It does take resources, and that's unfortunate because not every organization is going to be able to have those resources. So I think, yes, it has to happen at the local level, but it needs some level of network effect for people to be able to leverage what other health systems are doing in order for them to be able to effectively monitor themselves.
Yeah, makes sense. Santiago, Heather, Emily.
I don't know. I was thinking there's. I agree that the regulation is going to be difficult. The part that I think is particularly difficult is regulation of these kind of consumer AI products that are going into being healthcare.
Okay, let's discuss. This is a good. So we've got 5 minutes.
Right.
We've been given some grace of 5 minutes longer with the online audience. I think it's a good one to go into.
For example, Sam Altman on OpenAI, I think recently shared that a good percentage, I think it's top 5 of the topics that people chat about with ChatGPT is related to health, and I don't think. I mean, we don't really regulate that as a healthcare company, but it is providing a lot of healthcare advice that a lot of people are using, and I'm sure in many cases it's very useful.
Yeah.
I'm generally of the view that, it's probably the benefit is probably much higher than the risk for this, but I think it is an open question. Like, to what degree should this be regulated as a healthcare product? To what degree should it not?
Yeah. And in general, I mean, we've spoken in general about kind of specialist instances of models that are intended for enterprise use in healthcare, right? But you're talking about the ChatGPT that anyone, or Gemini or Claude that anyone can use.
Mm-hmm. Yeah.
Okay.
Yeah, I think for products that are internally used by healthcare organizations, I think there is already an incentive structure for the organization to kind of control that and make sure that it's safe and make sure that it's serving their patients best. With some of the kind of direct-to-consumer products, I really don't know, and part of it is I'm not fully aware of the regulation for it, but that I think it is a little bit more gray area.
Yeah,
to me.
for sure.
It's also, I mean, it is providing a lot of value. You can see in the use around behavioral health, and people are turning these tools when they probably may not have gone to a therapist, and so there's a lot of value. There's also some concern. I mean, we are trusting these models to have a certain set of values that are based on things that we believe. And just as an example, and we're in School of Public Health, I mean, we think about misinformation and around things like vaccines. What are these models trained on, and what are they going to recommend, and is that going to be aligned with what sort of traditional healthcare guidelines or public health recommendations are? So there is a concern with what these models will get trained on, what they will push to patients, and then the dynamic between patients and providers. Are patients now just coming with their own set of recommendations and just pushing providers to being sort of prescription mills and sort of taking the sort of decision making away from their healthcare provider? That's the dynamic that is likely to evolve.
Yeah. It's very interesting, isn't it? I mean, it's the context is, for most people, even in a very well-resourced situation like this, most of the time, the effective supply is very little of primary care in particular.
Yeah.
So in that gap, it's unsurprising that people are using the available intelligence that they've got, which is new, of course. But then that is going to have an increasingly distorting effect on their medical system. Okay, yeah, makes sense. Emily, did you have any thoughts? I could see you.
I think about this quite often in the ChatGPT use case, and I think there are just so many unknowns, and you think as like just a person asking ChatGPT health questions, which can be so helpful. It is it's trained on real healthcare data. It has learned from what an EHR looks like. However, what happens when I come and I say, and my Apple Watch said I got this much sleep, and my continuous glucose monitor over here is giving me this reading? Like, how does it know, that glucose monitor is like this accurate, and is your Fitbit like really telling you how much you slept, and was there other extenuating circumstances? And the amount of information that you as a user can give about like your peripheral health and the interactions there with what it's seen from what it's been trained on are, I think, a big unknown, and probably how a lot of people are actually using it today.
Yeah, okay, we've kind of come up against time, but I totally agree with that. I think this also sets up, we should have another discussion around that, the future of healthcare with these tools, and maybe we will, if we can kind of get the organization together. But it's, okay, we've got a minute or so left on the clock, so I think firstly all of us would like to thank the HSPH team who put this together. Most of you, particularly online, won't know who they are, but that's kind of why we're all here, the marketing teams of the Office of the Dean, and then also of Executive and Continuing Education, to Professor Rifat Atun, who leads Executive and Continuing Education. If you want to find out more of this kind of stuff, we've got a number of courses, including ones we all teach, where we've kind of obviously mentioned some jargon here that we haven't kind of gone into, and there's some frameworks for generally thinking about this. And if that's the kind of thing you're interested in, then join us. And I'm sure if you go to the HSPH Studio website, you'll be able to see the links to the courses on offer. But so wherever you are, thanks for joining us.